because of some, net issues that is going on in my place. So please excuse me for that. Um, and I'll be sharing my screen. So let me know if you all can see. Is my screen visible to
Yes, ma'am.
everyone?
Yes, it is.
Okay. So I'm just putting it on a presentation mode. So basically, we'll be discussing on palliative care delivery and the importance of the interdisciplinary team. Okay, so let us first start by understanding what is meant by a team. We all know what is a team, but then, just to recapitulate, just to find out whether we cross roads or not. So the team is a small number of people with complementary skills who are committed to a common purpose, uh, few performance goals, and an approach for which they hold themselves mutually accountable. So the definition of team itself, this whole sentence actually gives you an idea of what to expect and what not to expect from a team. Uh, and when we talk about the term interdisciplinary team, that means that it is described as an identified collective in which members share common team goals and work independently in planning, for problem solving, decision making, and implementing and evaluating the team related tasks. So basically, an interdisciplinary team would have members whose roles are already identified. Okay. And all the team members would be, complementing each other's work. All right. And they would share a single or, a few common team goals, and they would work, uh, you know, independently in planning uh, the process of how to reach that goal. They would also work in tandem to solve the problems that are anticipated. They would take decisions by consulting each other and implementing and evaluating the tasks. So basically, when we talk about palliative care, the importance of interdisciplinary team is very, very high, because palliative care cannot be delivered, or it is partially delivered if we are not in a team. Okay, whether we are doctors, whether we are social workers, whether nurses, uh, a doctor would always appreciate the help of a nurse. The nurse would always appreciate the decisions a doctor takes to, take care of the patient, evaluate and form the treatment protocol for the patient. And, we cannot actually understate the importance of a social worker when it comes to complementing in a interdisciplinary team. So the importance of an interdisciplinary team when we talk about delivering palliative care is extremely important. So what are the objectives of an interdisciplinary team? So basically, there should be an accurate and speedy assessment. Why accurate? Because, most of the time, our patients, the palliative care patients that we get, if we talk about cancer, we get, unfortunately, at the very last stage. Um, Palliative care has developed in India by leaps and bounds. But having said this, I am in palliative care since the last 15, 20 years. But then still, my patients for palliative care consultations would come in the last stage of their disease, which should not be there. It should always be at the very beginning of diagnosis of any kind of, seriously ill health. Okay. And why should we be doing a speedy assessment? Because we really want to start the care process then and there, whenever we get the patient. Secondly, it needs to be effective and an integrated treatment and care process. So this is very, very self-explanatory. I may not have to tell you more about this. Basically, what we need to do is that whatever kind of treatment or care plan we make, it needs to be integrated. Okay. It cannot be like, I will do my bit, you do your bit, and let us see where it goes. It cannot be like that. It has to be integrated. It has to be a collective action. So thirdly, the objective should be an efficient communication with the patient and the family, with other professionals, institutions, and within the team itself. So I would like to assume that every one of you, have gone, have actually underwent uh, uh, many situations in your life, in your basically with your professional life, where you have actually, uh, have had experiences with bad communication. Something you wanted to say something, but then you ended up saying something because of which the situation went out of your hands. So that should not be there. We should not be taking a chance with communication when it comes to the patient and the family. The very reason for that is that, the patient and the family are really dependent on what we say. They would actually believe in everything that we tell them, and um, it is very true because of the fact that they do come to us and in the last stage of their diseases, where they have been turned off by the hospitals. They have been, they don't find a doctor when it is when they have an emergent time. They are not able to talk about their condition, about their disease to anybody else. Okay. And sometimes it's like, when you offer to help, they would actually see you as next to God, whoever it is, you are the savior. You are my savior. And that's the reason why God has sent you to me. So we have to be very careful in our communication. What do we tell the patient? What do we tell the family? How do we handle the situation that the family and the patient is going through? It is not always that the patient and the family will totally rely on us. Okay, there are many instances I have myself gone through where the family is trying to find out, what kind of help am I trying to give to the patient. So you need to be very, very clear about your ideas of helping the patient and the family. So when you talk about your objectives, you give a clarity of your plan, and you practice to say no to things that you cannot do. For example, there would be many instances where the family would expect you to, give them some kind of a monetary help. All right. And it's a very common situation in our day-to-day practice, in our lives. So what happens is that one of the family members would actually approach you, take you to a corner, you know, talk to you in private and tell how much money they have actually spent with the patient. Okay. And they would actually ask you whether, your organization or, the hospital or, your whether you have anything to any monetary help to offer. Okay. And once you start doing that, uh, it becomes a very bad emotional trap, because you want to help the patient, you want to help the family also, and that's the reason why you end up contributing something for the patient's welfare. But then that becomes a cycle and you start getting irritated. So that is the reason why, even if you want to help the patient and the family monetarily, financially, you should refrain from doing that. Okay. But on the other hand, uh, you know, you should get them connected to organizations who the policy of which has a financial help for the patient and the family. That would actually suffice. But never ever try to do it on your own, because that's a bad communication, number one. Number two, it is not going to help the patient in the long run. Okay. So that is one example. Secondly, you should have a good communication with your own team, the extended team of other professionals who are working with you. Perhaps there is a psychiatrist, there would be a medical oncologist if the patient is a cancer patient. There would be a kidney specialist. Okay. So all these professionals also would expect good communication from you. Okay. Because you've actually got the patient from higher up. There has been a primary physician of the patient who has been helping the patient. But then now the patient needs palliative care help, because of which it has come to you or your team. And that's the reason why you should always try to have a good communication or good relationships with the previous professionals. Okay. And also, other professionals who might be able to help the patient. Similarly, good communication with institutions. For example, your institution or your hospital or your setup is unable to give the patient a bed. Okay. For example, I'm saying. So in that case, you need to get this patient an inpatient facility. So if you have a relationship, a good communication with other institution, they can always come forward to help you. All right. And that means that you also have a hold of what kind of care the patient is getting in the other institution. So this third point, the third objective, is extremely, extremely important. And then, audit of the activities and outcomes and impacts of the team is also very important. Until and unless you find out your faults by doing an audit, you will never be able to excel in your care process, or you'll never be able to come out with innovative ideas, improve yourself, and come to a standard where people would actually look up to you and take uh, take messages from how you have started to work and what you have delivered. So basically, how do people develop a team? So it's a very interesting process, and I'm really fond of actually this particular slide. I'll just go through, the formation, the stages of formation of a team. So what happens is that the first stage where a team starts forming is by coming together of all the team members. Okay. So by virtue of your department or your organization who want to develop a palliative care department or a service. Okay. So you all have been recruited, a doctor, a nurse, a psychologist, a nutritionist, a social worker, a counselor, physiotherapist. Everybody have been taken on board. All right. And we all know and understand the fact that palliative care is, it is a sense, it is a consciousness that comes from within. You want to help people. And that's the reason why people come to palliative care. All right. I am in palliative care because I have my own personal reasons to be in palliative care. Or otherwise, I would have been minting money by following some other discipline also. We all know that palliative care really doesn't pay off well to a person, but it is our choice. I want to be in palliative care because I want to help people who need my help. Okay. So the point that I am trying to raise here is that when a team of palliative care people come in, they come in with their own wills. Okay. Of course, they would be paid for their work, but then they also have a inner passion of coming to palliative care. So everybody who has been recruited to start off with a palliative care service or a team will have their own passion and they want to help the patient, by all means. So here, the stage of coming together of all these people is called the stage of forming. So now what happens, you have your own ideas, you have your own principles to work, you have your own timings, but then what happens is that there is a clash of ideas. Okay. The nurse would want to help the patient in a different way. She has some different ideas. She would actually tell that I have worked in so and so organization and we used to follow such and such rules. Okay. The doctor would actually tell you that, no, my idea is extremely different. I really do not agree to what you are saying. So my idea is different and my ideas should be actually applicable because I'm the doctor and I would like to actually treat my patient in my own way. And then there is this social worker who has had around 20 years of experience working in a social work environment or other a very well-known organization, and he or she would actually barge in and then give his or her own ideas of the importance of social work and all this. So everybody, the goal is the same. The goal is to help the patient. But then when they are trying to form a team, all their ideas, all their experiences are actually in a mess. They are unable to find out a common platform. And that's where, there is a huge storm that comes in that the team experiences. Okay. And this stage is called as the stage of storming. They would be bombarding, they start having fights, open fights. They start having, they actually go to their superiors and they said, I can't work with this person. He is just not of my type. The doctor would complain about the nurse, this nurse, she knows nothing at all. She's giving me bogus ideas. Okay. And the nurse would say that I have worked with so many doctors in my, past organizations, but I've never seen as arrogant as this doctor. The social worker would have his own ideas, give his own terms. And just as, the physiotherapist would actually come in, the dietitian might also have differences. So everything in one single room, and it starts bombarding. Okay. But whatever it is, uh, the as the team progresses, or, the superiors would actually know that, okay, they have come together, they will have conflicts. So let us give them some more time to settle down. Okay. And you have nothing to do but then to try and settle down. And that's the process where you start understanding each other. Okay. The doctor starts understanding the points that the nurse is giving. He or she starts appreciating for the work that she does. The social worker starts appreciating the doctor. And everybody in the team actually now starts giving constructive ideas. Nobody wants to go into conflict, forever and ever. So the what happens is that they start making peace with whatever they have. And that's where the performance, as you can see in this particular graph, it has the performance, the effectiveness of the team had started low when the stage was in a storming stage. And then it starts slowly increasing as there is normalization or the norming stage. And as they go, from norming to working effectively, efficiently, delivering a proper care to their patients, they start meeting their own goals. They are happy working in that environment. They are happy that they were able to have lot of success stories. They are appreciated as a team by other people, the other professionals in the hospital or in the organization. They are being appreciated by the patient parties, by the bystanders. So all these taken together, they start working even more effectively and efficiently. And the performance of the team is at the peak. I am not going to the disbanding of the team or adjourning, because I want you to focus on all the first four stages only. So, whenever you actually start working in a new team, please be wary of these four stages, because, it will make you accept the faults or the shortcomings of your team members very easily. Okay. And that would actually mean that you are developing skills which are needed for a proper team building. Okay. So this is particularly basically how a team develops and the stages that it goes through. And it is not only for palliative care team, it is also for other teams. It is also for a football team. It can be for a cricket team also. Okay. But when people start understanding each other's work and complement each other and appreciate their fellow colleagues, the performance of the team is at its best. So, coming to the characteristics of an effective teamwork. So basically, I have divided this into three main processes or three main categories. Okay, so the organizational structure to deliver an effective teamwork is extremely important. Okay, because unless and until the organization has a clear purpose and an appropriate culture of work, no individual in this world would be able to deliver or perform effectively. Okay, so the organization must have a clear purpose. It has to have a appropriate work culture. There should be specified tasks for everyone. The roles and designations of each and every person in an organization should be well defined. Okay, and then of course a suitable leadership who is going to show you the way to how to perform. And then you must have very good members in that organization who is going to actually complement you, understand your problems as an individual, brush up your knowledge, and then give you a cover when you have shortcomings. Okay, and of course resources are very, very important when because palliative care needs a lot of resources for patients. Okay. So individual contribution, when we come to individual contribution, the effective teamwork is definitely defined by the knowledge of that individual. Unless and until you have the proper knowledge of contributing towards patient care, okay, you will not be able to bring about a change. All right. There are many things that go on. If I have to speak about individual contributions, if I have to speak about knowledge, there are many people who would actually, take a flag and say that I am doing palliative care, I'm helping these people, that people, but when you actually talk to them, you can easily gauge what kind of knowledge they have about palliative care. Okay. I'm not only talking about lay people, I'm also talking about doctors. Many doctors do not know the ABC of palliative care, yet they would actually tell you that I have been doing palliative care since a long time. Okay. I myself have come across doctors who would actually, put the patient in an ICU, a dying patient in an ICU, and then they say that I am doing, this is the palliative care that I have designed for my patient. So, the accurate knowledge of that individual actually shapes up the correct kind of, the right kind of palliative care that is needed for our patients, for palliative care patients. And we cannot understate the importance of trust, the amount of commitment that we need to give for such kind of a work. So I hope you will go back with a lot of good learnings after this course, and I'm sure that your commitment to help people in palliative care would even rise higher. So commitment is an important contribution from an individual. And of course, there is a question of flexibility of work, because many would want to do palliative care out of their, out of their mainstream of work. Many people would take it up as a kind of social work also. We cannot also underestimate the processes that are involved. For example, how the team is coordinating, what are the communication skills that are being used, the kind of cohesiveness that the team members have built up, the importance of decision making, how the conflicts inside the team has been managed, and of course, other social relationships, and what kind of feedback has been there for the performance of the team. So these are the very important characteristics of an effective teamwork. So I will now come to the palliative care team. Okay. And as I have been saying right from the very first slide, that teamwork is an inherent feature of palliative care. Okay. People, there are, solo practitioners model of palliative care, but, you will always find somebody who will come and join you and help you in delivering the proper care of a patient who needs it. Essentially, the IDT has its own characteristics and own challenges, and palliative care IDT should be both defined and flexible. Okay, I'll come to what defined and flexible means. So the palliative care team generally will have a core team. Okay, and the core team is always a physician and a nurse, and they are the essential members. See, why I am saying this, please do not, misunderstand me in this point, because when we talk about patient care, it is definitely, we talk about the physical problems of a patient. Okay. Let me give you an example. So yesterday, what happened? I had a severe headache and I was not able to actually concentrate on my work. Okay. And there was this friend of mine uh, who was trying to relax me. And she was coming me and she was telling me, okay, don't worry. You may not have slept well. That's the reason why. So I really did not want to hear what she was saying. I just wanted that somebody should give me an aspirin so that I can just get rid of this pain. Okay. So it is the same thing when we talk about our patients. Our palliative care patients, have a high load of symptoms. They might be having a 20 days of constipation. And at that point of time, that patient would actually want to get rid of all the stools that are inside the abdomen. They would want somebody to help them out, take out that particular stools. Okay. Uh, but if somebody comes and tells me, okay, don't worry, you'll be fine. You should have a lot of papaya. It's going to help you. And, he will actually tell you, the patient will tell you that I've already had papaya and it's not helping me. Okay. So that is the reason why physical symptoms need to be addressed right at the very beginning. Okay. And when we talk about cancer patients, I'm sure many of you know how what kind of a dreaded disease it is. And terminal patients, terminal cancer patients, will always invariably have a lot of pain. And pain management is an important measure when we talk about giving complete pain relief to the patient. That is the reason why the core team of a palliative care team is always a physician and a nurse. Okay. And then definitely the importance of a social worker, the pastoral worker, the chaplain, a pandit, there are many therapists. One of my colleagues is a music therapist, and she has been, doing very well while we do while we prepare the patient and the family for the coming days where it would be very difficult for them to actually go through that painful process of letting the patient go. Okay. And I'm talking about the end of life care. So, the importance of social worker, chaplains, pastoral workers, physiotherapists, dietitians, music therapists, dance therapists, these can never be actually replaced. Okay. So, a core team would be a physician and a nurse. They are the essential members, and rest of the list would be actually, you can keep on adding whoever, because everybody uh, will be able to help the patient in one way or the other. And when we talk about an extended team, then of course, all these that I have mentioned already, and a specialist palliative care team, where you have somebody from oncology, a doctor or a nurse from neurology, a respiratory specialist, and then the cardiac and nephrology, etc., etc. So, you can actually extend the team a lot, and the core team shall remain the same. Now, the question that is very, very important here is, are the patient and the family members also part of the team? And the answer is absolutely yes. So palliative medicine is always patient-centered, and all treatments have to be given with the patient's consent and in accordance with his or her wishes. So what happened earlier, is that the patient was never asked. He was never taken into consideration what he wants. He would be just, taken to the hospital, and then there would be a team of doctors who would actually come and discuss everything in front of the patient, but then patient is not able to understand anything because it is all jargon for him. Okay. But in palliative care, in palliative medicine, the patient's consent and it has to be in accordance with his or her wishes. We cannot actually take out the patient and discuss about his or her body. It is his right to know everything. What is going on? What are the injections that have been given? Whether he understands or not understands, the patient is going to tell you. But your work, your duty is to take the consent of the patient before you do anything to the patient. Okay? And he must be considered a part of the team. The family members, in India, we have a strong family bonding. So family members have to be a part of overall care of the patient, and their opinions should be included when we formulate a plan of treatment and care. So what are the interdisciplinary members? I've already told you: chaplain, occupational therapist, music therapist, physiotherapist, dietitian, nutritionist, somebody who can contribute to mobilize him also. For example, a sports personality, somebody would actually want to fulfill the wishes of the patient also. So all this, you can go on adding actually. So what are the different settings where you can deliver palliative care effectively? So number one is home. We all know home care is very important for terminal patients. And there can be an outpatient facility. There can be a daycare center. There can be an acute care facilities where patients with very, distressful symptoms can be taken, and they can be admitted in an emergency. Emergency measures can be taken for those patients. And then, of course, specialist palliative care units and something called the hospice. So coming to the home care teams, they will provide specialist advice and work alongside the community personnel. So the importance of the community is also very, very much there. Okay. And, the community personnel or a volunteer, they can be social workers, they can actually be paid volunteers, they can be local general practitioners. These are the community personnel. And the community workers, they can generally coordinate the care of the patients, and they form a bridge between the specialist palliative care team and the home care team. So that is how home care teams would actually function. So having said this, home care also has a set of advantages as well as disadvantages. So basically the advantages are that, we know that 70% of patients would prefer to die at home. And it is not me saying it. There are studies that have actually found that 70% patients, palliative care patients, would want to die at home. So the basic advantages are that more autonomy and privacy and freedom for the patient, and the patient feels very, very safe at home. Okay, and it is well understood. Even if when you are in that stage, you would actually want to go back home, isn't it? How many of you have had long hospital stays and have always died to wanted to go home all the time, expecting that the doctor today, if he comes for the rounds, I'm going to tell him I'm not going to stay in the hospital for long. I just want to go home. I need my bed. I need my room. I need my toilet, So that particular preference is very much there for all patients. And at one point of time, when our patients have understood that, I may not get better, that I am actually going downhill. So what is the point of spending time in the hospital? I want to go home. So that's the reason why home care, gives this particular platform for the patient to voice out and say that I want to feel safe. I want to be safe at home. The family at home, if the patient is at home, they can anticipate the loss. There would be a better bereavement period for the family, and they would accept death as a normal process of life. Okay. In the old days, maybe 30, 40 years before, what happened? Many of our people, our grandfathers, our grandmothers, old people, sick people would be at home. They would actually die at home, and there would be so many rituals in and around that dying process. In Assam, I am from Assam, so in Assam we have a lot of rituals, because we know that our person would be dying maybe in another 2 to 3 days, and we have so many rituals to perform, chanting the Bhagavad Gita, and then offering certain things, on behalf of the person, going to certain mandirs or namghars and so many other things. So all these things are a part of the normal process of death. And, as healthcare is modernized, death has also been institutionalized. We are unable to accept that somebody will die in this process, in this huge scientific era of so much of progression. Okay, but death is the only truth and only truth of life. So we have to accept that, and it is a normal process of life. So it also reduces a lot of care, lot of cost of care, prevents unnecessary hospitalizations. And that is well understood, because we, just for taking a drip, people run to the hospital, which is not required at all, okay? And that can be managed at home also. So these are the advantages. But then having said this, there are disadvantages also. For example, if the patient himself or herself says that I want to be in the hospital, then you should not go against his or her wish. Okay. There would be patients who would be living alone in very far off places. And if their care process requires, skilled care, for example, a specialist palliative care, then you may have to actually admit the patient. For example, in cancer, if the patient has uh, developed lung metastasis or the cancer has spread to the lungs, then there might be a condition where he has developed refractory breathlessness. The patient is always breathless, okay, and that might be very difficult to handle at home. Even if you start giving oxygen, the patient is not getting better, or the patient is not actually able to show you signs of stability. But it becomes very difficult for the family to handle. And at that point of time, you may have to take the patient to a center, higher skill center. Now, the family might be physically or emotionally tired. There's just one daughter-in-law who's been looking after her old, in-laws, father-in-law and mother-in-law, of whom the father-in-law is bedridden and the mother-in-law is in the last days of life. She is just not able to take care. Okay. And that is the reason why I say that she might be physically and emotionally tired. She is not able to deal with uncontrolled symptoms. She cannot meet with minimal comforts needs. Okay. So that is where we might have to think about taking the patient to a higher center till the time of death. And then the burden of care shifts to the caregiver from the team. The team would actually come and say, give their advice, for the time being. But then when the team is gone, the whole care burden would shift to the caregiver. So these are the disadvantages. So you can see there are some pictures of home care where on the right hand side, you can actually see the caregiver is how they are taking care. If you have had opportunities to go on a home care visit for such patients with any of the teams, you would actually appreciate the importance of home care. Similarly, outpatient facility for palliative care are also there, and they also have their set of advantages and disadvantages. Patients can have a consultation from a multidisciplinary team in a outpatient facility. There can be opportunities where there can be family meetings, there can be a lot of counseling, a lot of support group activities, okay? Basically, these things are seen in a cancer setup where, suppose there is a breast cancer patient and this patient has actually joined or has been detected very new, and she has been trying to find out other ladies or other females who may have had same treatment or same diagnosis. So there are a lot of people who can be of help as a support group, and that can happen in the same place in an outpatient facility. And in case of very severely symptomatic patients, a daycare symptom control can be easily arranged. But having said this, there would be disadvantages also. For example, the patient may have to wait in long queues in the OPDs, okay? There are a huge footfall of patients, and the patient may have to spend the whole day waiting for one single consultation. There can be space issues, Severely symptomatic patient may require a more comfortable space, but unfortunately he's cramped up in a small wheelchair. He's not able to sleep on a comfortable place. At the same time, consultants from all disciplines may not be available on the same day. So there can be repeated visits that may be required. So similarly, for a daycare center also, advantages are that the symptom control can be easily achieved by keeping the patient under close monitoring. Patients can go home after a short day course of medications or interventions, for example, a blood transfusion, which is very important in palliative care, because people become anemic, because of the chemotherapy, because of the treatment that is going on. So a daycare center can be of huge help. But at the same time, it may not be as cost effective as a home care. Okay, it might have its own disadvantage of incurring a lot of cost. The treating team may admit only those who are not in the end of life. That is one important thing. Okay, they might have a protocol where they will say that only those patients who are not in the end of life would be admitted in the daycare. Acute care facilities are basically intensive care units. And as you can see, this patient might be in a very bad shape, okay? And he would need some kind of intensive care for his symptoms to be taken care. For example, semi or unconscious patients, there can be a problem of acute breathlessness. There can be, a cardiac problem. So this care basically is provided as an adjunct to the main specialty. So this is actually a picture of my hospital, and this is my team. And we actually performed the patient actually came with a acute pain crisis where, he was not able to even, say a word. He was in extreme pain. And then we managed the pain with morphine, IV morphine trial. And you can actually see the smile on his face. So specialist palliative care units are actually designed for terminally ill patients who would require intensive involvement of a specialist interdisciplinary team to manage their complex problems. They're all, the members would be exclusively trained in specialized palliative care. All these nurses that you see are all specialist palliative care nurses, okay? They have been working in palliative care since donkey's years. And, they would the function as an inpatient stabilization unit and manage the uncontrolled symptoms at the end of life. So this patient was, actually passed away after a week of taking this picture, as he was in the last stage of his lung cancer. But then he passed away very peacefully with us. And then last but not the least, the hospice. Basically, let me just give you an idea of what a hospice is, because many people have different idea about a hospice. So the word hospice actually came from the concept of a traveler going for a pilgrimage in the very, very olden days. It was something in the 10th century BC. Okay. So what happened is that because of certain diseases which would actually kill the patient, people used to go to the highest order of the church. And I'm talking about in the West because it's a Western concept. So they would actually go to maybe the Vatican or some other place where they would offer their prayers so that they can get well. But what happened in the olden days, the transportation system was also not good. So they had to travel for days and weeks and months in order to get there to that particular place. So in the journey, there were certain places where they had to spend their nights, and later on those facilities or those places started developing as uh, shelter homes for such patients, because many people would be actually have started their travel a month ago, but within a month and during the travel they would have actually deteriorated, and many would die in such condition. And when they die in those places, they started developing people who would care for those dying people. Okay. And that's how the concept of hospice came, because it comes from a word hospital. It is very relevant to hospital, but then, it gives uh, the idea of those people, those patients who do not have much longer time to live. Okay. And they would actually come and spend their time till their deaths in the hospice. So this is the concept of hospice. And so that is the reason why says that hospice ensures the best quality of life and the best quality of death for patients. Okay, so these are the examples that you can see. In India, we have certain hospices by the name of Shanti Avedna in Mumbai. Shanti Avedna in Mumbai was the first hospice in India. And there is a similar Shanti Avedna in Delhi also, just near Safdarjung Hospital. In Guwahati, in my place, there is this Sacred Heart Palliative Care Center, which is also a hospice. Then you might have heard about Karunashraya Hospice in Bangalore. So many hospices have actually, they have started in India of late. So I would like to now, dedicate the rest of the time of this discussion for a very important topic, which is the social work in palliative care, because it is very understated, to be very frank. As I've told you earlier, social doctors and nurses have been given a lot of importance. But having said this, the role of social work in palliative care is humongous. It is huge. Okay. And, I have myself worked with many social workers who have, by all means, have contributed to patient care. So the social work role, there are three forces that shape this particular role. They would have a non-medical social goal. Okay. When I say non-medical, everything that is not medical would actually be their goal. For example, arranging a ambulance. It's a very small thing, but arranging an ambulance in itself is a huge work. The teamwork and multi-professional skills that is required to meet the non-medical goals is also important, because unless and until you do that, you are not able to meet your social goals. Last but not the least, the expectations of patients, carers, relatives, friends, various professionals in palliative care, including the social workers, also give a shape to the role, these particular roles. The patient will have his own set of expectations. The carers will have their own set of expectations. As I told you about the financial aspect of care, the relatives might actually want the social worker to arrange for, a free health card. All right. I'm just giving an example. So all these things, this force also shapes the social work role. So when we talk about non-medical goals, I've already told you, these are everything but the medical goals. So expression of emotional pain, the need for exploration of spiritual pain, the need for practical help. All these three things taken together, if you start jotting down points in these three areas, you will know the kind of humongous work that our social work colleagues are doing in palliative care. Basically, the perspective is that what is that the social workers cannot do? Definitely, they cannot cure the pain. They cannot dress bad wounds, and they cannot really offer religious rituals, appropriate religious rituals. So these things, are seem to be very small when we talk about the larger role of a social worker. Okay. And secondly, to see the patient as part of the family and social network. Thirdly, to understand the implications of special situations for the patient. For example, the mental health legislation. Who is going to actually tell the patient and the family about the mental health legislative things that is presently workable in a country like India? It is not the doctor. The doctor doesn't have any knowledge about it. It is not even the nurse who is going to do it. It is the social worker. So again, I repeat, it is a humongous work. So basically, they would work in a lot of assessment of the patient. There are many things that, many forms or many scales that are used in social work to assess a patient, a person, basically a person. Okay. And when I say person, it may be the family member of the patient also. Because as I said, the patient and the family is one particular unit. Okay. Then comes the intervention side. What are the interventions that can be done after an assessment has been made? Okay. And if the patient has died in the hospital, what are the bereavement support that needs to be given? If the patient has died at home, what are the bereavement support that needs to be given now? Okay. What are the wider roles that a social worker might also have other than the assessment, intervention, and bereavement roles? So all these things taken together are the main areas of social work. Coming to assessment, of course, emotional, social, practical, financial. These are the basic assessment that needs to be made. Identifying any need for further assessment, coordination between disciplines, that is also important. My social worker actually is running around from one consultant to the other just to make one process easy for the patient. She also runs to the social welfare board to just notify that this particular patient has lost this card and the PMJY card, and this needs to be replaced as soon as possible. If it doesn't happen, that patient is not going to have the third cycle of chemotherapy that is due. Okay, so coordination between disciplines is also very important, and that is done as a part of assessment of the patient. The need for specialist help and assessing basically at 4 levels: the individual, family, the physical resources, and social resources are also very, very important. Coming to interventions, you know, basically they are aimed at patients and families in need of help to cope with their situations, and those might be the adequate and appropriate information, facilitating proper communication to reach a solution, imbibe the confidence to act as and when required. Okay. And then facilitate required resources, facilitate bereavement support, and facilitate many other uh, expectations that the patient and the family and the palliative care team might be having. Bereavement is an important role of a social worker. They are experts in giving one-to-one bereavement support. They are very good counselors. They would be, wherever needed, they might actually create a bereavement group for counseling, and then suppose if there is a person with an extended grief, for example, parents have lost their young child, so all these things would actually need a lot of bereavement support. The wider roles is, of course, community liaison, where you would actually try to get a routine general contact with many people in the community. Creating a care package would be very specific to a person, to a patient. The facilitating and mobilizing community resources for the patient in question. Education of the children, particularly those children whose parents, both the parents, one of the parents have actually passed away and the other is a patient. So those children would actually need help in many areas of life to sustain themselves. Uh, and suppose a father, uh, the father was a patient and has died recently, would one of the kins or the family member get a job on the in the place of the father? So all these things are actually, we know all these things, and I'm sure you also appreciate these points. But the thing is that these are generally done by the social work team. Involving the family members in the care process, establishing long-term relationships, uh, awareness generation and education is so very important role of the social worker, because uh, doctors would be invited for a talk, but it is the social worker who's actually organizing it. All right. So that is where, the involvement of the social worker with the community volunteers come in. And that is where, the seeding of education and awareness generation in palliative care is appreciated. So I have actually tried to cover a few points that are very, very important in this particular topic. And having said this, the field of social work in palliative care is definitely a newly emerging one. And if any of you are already in this profession, I would personally salute you for the kind of humongous work that you do. And those of you who are actually thinking on the lines of, uh, you know, doing palliative care social work, there are many, many courses that are outlined in India. There are, they have, you'll appreciate the IPC's courses, the Pallium India's also have a course, I think. I'm not sure about it, but there are institutions that have developed palliative care social work courses. So I would actually give you an encouragement, a thumbs up to take up that particular course. So thank you so much for a patient hearing, and I am ready to take questions in whatever way. So thanks for a patient hearing.
Hello, ma'am. Ma'am, we do have
Yes.
questions in the chat box.
Okay. All right. So
So from the beginning, can I read out the questions?
yes, please do, please do.
Yeah. Is knowledge of local charities and government policies for financial help a request for the palliative care professional? So this is the
Okay.
first question.
Okay. Yeah, I think this is Shalaka Parab.
Parag.
So I don't think it's a requisite. Okay, it cannot be a requisite. As I said, it has to come from your end. If you are, you want to help the patient financially, nobody can stop you. Okay, but you have to see your boundaries, because I really don't want you to end up utilizing your own money for such patients. I mean, sorry for using the wrong word, not such patients, for such situations where you would actually one day feel, oh my god, why am I doing this? It's not paying me off, it's actually robbing me of my money, I'm in the wrong profession. That should not happen. So you must know where the finance is there, who are the people who are ready to give you donations, who are the bigger players, like we have corporates who are actually giving out money for financial help for as part of their CSR activities. So you can actually tap them, but I can't really say that it's a requisite. It's always good to have a knowledge of these people. For example, in my place, I know which agencies are there uh, that I can actually go and seek help for my patients, those who would need some kind of financial help. Okay, so it cannot be a requisite. So that is one answer. And Shalaka has also asked about this physician in the core team is the disease specialist or a palliative care specialist. Okay, that's a very interesting question. So I have actually given you two things. One is the core team, another one is the extended team. Okay, and the core team is always by the made by the palliative care physician plus the palliative care nurse, because we are actually talking about palliative care. Okay. And when I talk about the extended team can have many disease specialists. For example, a nephrologist who deals with the kidney diseases. End stage kidney diseases also need palliative care. So, the palliative care physician may not have adequate knowledge of delivering the kidney related medications for this patient. He will have to take help of the renal specialist or the specialist who deals with kidneys. So that is why the disease specialist would be definitely in the extended team, and the core team would be a palliative care specialist. Does that answer your question, Shalaka?
Yes, but I was also wondering if most of the palliative care specialists in India are very cancer focused, and would they be able to address cardiovascular palliative care needs or neurological care
That's,
needs?
that's a very, very pertinent question. I'm really thankful that you've actually asked this. So what has happened, Shalaka, is that, when palliative care started with the concept of cancer. Okay. So what happened is that cancer is a very high disease burden, symptom burden kind of a disease. You see patients deteriorating even for taking chemotherapy. Okay. So that's the reason why the concept of palliative care started with cancer patients. Okay. So if you have had an introduction to palliative care, you may have come across the work of Dame Cicely Saunders. So Dame Cicely Saunders basically started her work in and around cancer patients because a lot of symptoms need to be handled, by the uh, uh, palliative care specialist in cancer patients. But then, as time went by and the other diseases started taking their shapes, the cardiovascular diseases, the kidney diseases, the lung diseases, respiratory diseases, they also have had their own share of, disease symptom burdens. And that actually required a palliative care specialist to learn about these specialties also. Having said this, a palliative care specialist needs to learn about all the systems in the body. Okay. He needs to learn about the serious diseases. He needs to learn about the kidney diseases. He also needs to learn about the liver diseases. He needs to learn about the gastrointestinal tract diseases. But then he cannot be a master of everything. All right. That is the reason why we need specialists of that cadre. For example, uh, one of my colleagues who is basically a respiratory tract disease specialist, takes care of COPD and lung diseases, has also had an additional training in palliative care. Okay. So I can actually reach out to her to take care of such patients who are in that particular section. Okay. So that is the reason we cannot actually say that palliative care physicians are cancer focused. We actually have to say that now it is getting diversified for the reason that so much of disease burden is seen in the community as of now. And you'll appreciate the fact that, uh, uh, you know, the long-term facilities, 70% of the patients will actually be in those other non-malignant categories. Only 30% of these patients will be cancer patients, end-of-life cancer patients. Rest of the patients would be either paralysis, they will have either, a heart-related ailment, they will have either, a kidney-related ailment. So that is the reason why now even palliative care has got its own super specialties.
And Dr. Bora, if I could ask you just one last question on this. So, these palliative care specialists who are doctors, what kind of professional or academic credentials do they have? Is it a fellowship, an MD? I'm asking about, if they're trained in India, what is it that we should be looking for?
Yeah. So basically, we have a lot of fellowship courses in India for doctors, for nurses also. And now they've started with, pharmacists and many other allied subjects. But then recently, I think last 10 years, we have been running MD in palliative medicine also. And Tata Memorial Hospital in Bombay have started the MD in palliative medicine. So basically, you if you really want to go to a specialist, you should actually look for somebody who's an MD in palliative medicine. And of course, just not an MD, perhaps somebody who's also have had a lot of experience in taking care of palliative care. Somebody who's spent his or her life in, 20 years, 30 years of life in palliative medicine would actually give you a better idea of a patient's care as regards to a very new person who have just done an MD. So yes, I would actually suggest you to do that.
Thank you.
Yeah.
Thanks so much.
Yeah. Okay. All right. So yeah. So there's a comment here. I think Shweta. India being a very culture-oriented country, family often plays an integral role in decision making, and sometimes, unfortunately, patients themselves aren't involved. Yes. In some cases of patients diagnosed with cancer, I have often seen family members requesting the doctors not to disclose the diagnosis. Okay. So, what is the opinion on the same? We can psychoeducate the caregivers about the importance of the patient knowing, but still, if they persist. Okay. So this is, I really don't want to disclose this because I'm sure you are going to have a great session on communication skills. Okay. Because communication skills, as I have already, in my presentation also, I had given a lot of stress onto. But then if I actually curtain raise now, you will lose all the interest and the but then having said this, please do attend the communication skills session. I'm sure it's going to be very, very interesting because this is a situation where we have been facing this situation since donkey's years, that we have been practicing palliative care. People do not want their patients to know about their diagnosis, and the skill is your skill is examined when you know how to manage both the parties. And it's always important to disclose the diagnosis. If I have to say, it's my body, I have the right to know what is happening to me, or it's my body and I do not want to know what is happening. So both of these situations are equally important, and we just cannot, say that, no, I have to tell you, so I will tell you, or no, I can't tell you, so I will not tell you. So has to be always patient-centric. So just wait for some time. I'm sure you will have a very good communication skills session. Okay. Sweta, I hope I am able to satisfactorily convince you. Okay.
Yes, ma'am. Thank you.
Okay, Sweta. Yeah. All right. So Sweta is another question. As caregivers, sometimes they might feel that they might not be able to provide the quickest care for the patient if they are sick at home. Okay. So if the patient passes away, wouldn't it make them feel guilty or make them feel they haven't done enough? Yeah, it's always, this is a very common situation, because uh, tomorrow if something happens to my father and I rush him to the hospital and, he passes away in the hospital, I would have always thought, oh my God, why didn't I take him to Delhi? Oh my God, why didn't I take him to America? So, this guilt will always be there because of the inherent sense that we always want to do the best for our people. There is no limit to the kind of limit to a satisfaction level which will actually tell you that yes, you have done a great thing for your parents or your patient. So that thing, I think it's the people come to terms very slowly, and it definitely depends on the kind of situation that they're in. And for this kind of a situation where trying to provide the quickest care. And if I have to, translate the phrase quickest care, I would say in terms of medications, or in terms of the kind of interventions that we are able to provide at home. So those things are quite dicey. Those things are quite, tricky in for that matter. And that is where I would actually, give an importance to our counselors, and the kind of, you know, the conversations that would take place in that particular place. I mean, in that particular situations, because as a team, when you go to the patient, you know that this has been going on, and you anticipate that the patient might actually pass away within a day or two. Your role as a counselor would actually become more. The role of a doctor might be a little less, because the doctor has not much left to be given to that particular patient. All that he or she would do is to make him a little more relaxed, comfortable in the same place that he is in. But the kind of conversations that you do with the family member would actually be very, very, very therapeutic. And that is where, these kind of feelings, this kind of guilt that they might slip into can be avoided. Okay. All right. So Sweta has also. So also, I feel it's important for the doctors to psychoeducate the caregivers on the best option, so that the caregiver can carefully take decisions without facing a dilemma during critical moments. So this would help. Absolutely. I completely agree. And that's the reason why, Shweta, doctors in palliative care go through rigorous communication skill training. And, we have to actually go through refresher courses in palliative care. If we don't do that, we have a tendency to fall back into the same, conventional, traditional doctor type things, human beings. So we do have that particular refresher courses for doctors also, for palliative care doctors also. Okay, there's somebody in Narmada. Okay, what is a good method for caregivers and the patient to decide whether they need to stay at home or go to the hospital, OPD, or daycare? Could you elaborate a little further on how this is evaluated by the palliative care team and how? Okay, very good. So this is a very important question. And definitely, you see, we have something called prognostication. And when I say prognostication, it means that you have to anticipate by the kind of progress, physical progress that the patient is showing. For example, there are certain signs and symptoms which will actually tell you that the patient is not doing well. Okay. So we have a medical criteria where we can prognosticate the progress of the patient. It is very easy in case of cancer, because we can, it is like a steep fall, all right? But if it is a long-term disease, for example, dementia, okay? So there would be a curve which will be very slow in coming down. So those are actually called the paths of progression. And being a doctor, you have to know what kind of path the patient is on. If the patient is a dementia patient, you know that the patient is going to have a dwindling kind of a fall. If the patient is a cancer patient and is at the has had all chemotherapies and radiotherapy and surgery and everything. And as of now, the patient has been showing signs of deterioration since the last 2-3 days and is not actually coming up to a satisfactory stable level. You know that the patient is actually falling down. So it is the prerogative, it is on the prerogative of the doctor and the medical team to actually decide which state the patient is in and then take a decision on communicating this to the caregivers. And that is how we tackle such kind of a situation. Okay. So for the patient to stay at home, it is always important to understand what kind of situation does he really have a good supporting family. Is there only a daughter-in-law who's taking care of the patient and also cooking the food? So you have to find out, and that's where the social worker comes in. That's where the counselor also comes in. Okay, finding out the place of the stay. Is it very far from the hospital? So these things, these factors would actually be taken together to decide, and you'll have to give that as a platter to the patient and the party, to the family, that we have these options for you. If you want to stay in the hospital, these are the options. If you want to stay at home, then we can provide you with these support. Okay. And if you decide to stay at home and you have a problem, there's something like a fever which is not actually coming down, you can always come to the daycare. We can evaluate you and then we can take care of the fever and can go back. Or feeling very weak and we find out that the patient's hemoglobin has gone down, so we can always try to bring the patient to the hospital, keep him in the daycare, give him a shot of one pint of blood, and the patient happily goes back. So these are like the decisions that the medical team, generally the core palliative care team, would actually decide. Is that okay, Narmada?
Yeah, that was great. Thank you for answering the question. Thank you.
Okay, and there is somebody called Darshana. So how does a palliative care team tackle a situation where the patient or their family are parallelly consulting with other external stakeholders like alternative medicine doctors? Okay, so we are following the Indian system of medicine. Okay, we are following the allopathy stream of medicine, and we would not encourage alternative medicine like homeopathy, etc., because we really do not have the knowledge. That is one, whether they work for palliative patients or other patients or not. Secondly, these systems, I think, do not have much of evidence-based practices, because I myself have not been able to find out any evidence in the scientific literature about how much they work for. It's not like somebody has told me, that one of my relatives have, had this much of relief with that particular Ayurvedic medicine. I wouldn't really want to go by that. I am a scientific person. I am a new age person. So I would really want some evidence to be there. And I really would want to request you all to follow that also, please. Just do not go by words. Please try to find out. There's a huge literature out in the open, which will give you a lot of evidence for a kind of practice. Everything that we do in palliative medicine is evidence-based. Why? Because number one, it is allopathy. Number two, every practice has an n number of evidences that you'll find in the scientific literature. And that is where our colleagues will actually ask, questions to us. Why have you done this? Why haven't you given this particular medicine? Why have you given this particular measure to this patient? Why not that one? So I must be able to answer the question with an evidence, with a proof. So that is why, if tomorrow, if I find, 2 randomized controlled trials for a homeopathic medicine that is working for one of the palliative care patients, I would readily agree to them. But till now, I'm sorry to say I haven't found, nor my colleagues. And that is the reason why, I wouldn't call even their, call them that they are external stakeholders. But having said this, the patient and the family are free to go for any kind of care that they want, any kind of treatment that they want. It is our duty to guide them, tell them the truth, and we have done that. But still then they are, they are actually wanting to go, then we are nobody to stop them. It is their decision and we have to respect their decision. Darshana,
That helps.
okay?
That helps, ma'am. Thank you.
Okay, thank you, Darshana. Okay, and anything else that okay, so Gitanjali Sahu, wow, you are a medical social worker. Lovely to meet you, Gitanjali. And you are in an eye institute in Bhubaneswar. That's very nice. Okay, so in Bhubaneswar, they have started, Gitanjali, they've started with the Bakchi Karanashraya Palliative Care Center. It's very new. I think they have taken the first patient yesterday. So, you can actually go and meet Dr. Praveena Karnam. She's a colleague also. She's the associate director. And, you can give my reference and then, you might find something interesting there. Yeah, Gitanjali? Okay, so Gitanjali is also asking about government schemes in India for palliative care patients. Unfortunately, no scheme, but there is a national palliative care program, which is, which has now started taking shape, and there are funds for, palliative care in the area of training. So through the NPPC program, they have started to train district doctors and nurses, and the ABPMJY, the Ayushman Bharat scheme, they have certain packages for palliative care patients, and you can actually go through those particular things. So you can get all the details there. Okay. So anything else? But that is also for oncology. Yes, of course. That's also for oncology. Oncology, and there are packages in, medicine, which covers palliative care for kidney patients, palliative care for cardiac patients and heart patients also. Yeah, Gitanjali, definitely I'll share. I think, Ashley, you have my contact. You can share with everybody out here. Yeah.
Yeah.
So any other question, any doubt? I think this has been very interactive. I'm really happy to have answered so many questions. Thank you so much to everybody who's there.
Thank you, ma'am. Thank you for the wonderful session. So we are having a small case presentation model reading also as well. So if
Okay.
you wish, you can continue. Otherwise, no worries. Like, yeah.
Okay, maybe if you would excuse me for today, I would like to leave, and please continue with your great work that everybody is doing. And
Okay.
I'm really happy to be here. Thank you so much, and happy Eid to everyone.
Thank you, ma'am. Thank you so
Thank you.
much. So I'll be sharing a case model. So it will barely take 5 minutes. So I hope it's visible.
Yes.
Oh, so this is the first slide of case presentation where you have to list your name, your designation, and your organizational affiliation as well. And this is a patient overview where you have to list about the patient, like the age, the gender, and which is what is diagnosed with. So here it's a 7-year-old, which is a male, and is diagnosed with cerebral palsy, hypothyroidism, and also seizure disorder, where the occupation is like nil. And this is the medical history, which is like diagnosed with cerebral palsy, hypothyroidism, seizure disorder, and since birth, the patient was suffering from illness. And the early interventions also took place, and somehow physiotherapy also helps him. Sorry for that. Helps him to have some slight changes as reported by the infant. So here in this particular case, we have this case from our telehealth center. So this is the case which was reported from our helpline number, and which was the patient was like completely bedbound and also lower food intake, which takes about like 2 to 3 hours to feed, and he was also weighted only 6.5 kg at the age of 7. And this is the insight, which is like insight on diagnosis, prognosis, and also palliative care, where the patient, since I was told earlier that the case was come to us through the telehealth line. So since we don't have like particular, sorry for that, since we don't see the patient directly, this is all the facts which the patient's father and the auntie and has told us through the telephones. So the family is like known of the illness through doctors only, where all the families except the child's mother has known that it's like a serious illness and has like moved on. Yes, Angel. And the child's mother still now believes that a chance of recovery in this particular case of that child. And also in the palliative care, we are like aware that it was like a bedridden case since of the serious health related illness. And this is the family overview. Here we can see that while drawing this family overview, we have to know that there are like, while drawing this, like 3 generation past. Yes, Sri Priya.
Hello everyone. Just wanted to update that seeing this family overview, no need to get tensed or anything. There is no hard fast rule that you should make the uh, genogram like this only. You can even draw this in a sheet of paper and paste it in the PPT. uh, there is no need that it should be like this only, the same format with all these shapes and figures well defined. There is no need for that. If you are not that tech savvy, you can just draw it out in a piece of paper and take a photo and paste it in the PPT. That will also do. I just wanted to update that. You can continue, Ashley. Thank you.
Okay. So this is the family overview. So here, this is his father and his mother, and coming down, we have like 3 more siblings with him. So this is like family overview. Here, like the square which represents the male, the circle female, and a triangle with X mark in is like represent the miscarriages. Sorry for that. So I think it's clear, like if you have any doubts, you can ask later or now. Like, so I hope it's clear. And this is like
What is the objective? Ashley, if I could just go back to that. What is the objective of this family overview? What are we trying to communicate here?
so this is while we are taking the cases of each person, while like writing their documentally, we have to, this is like one of the main factor in social work that we studied there, that we have to enlist all these documents so that only we can go to a conclusion in the end. So while documenting, this family overview is really important.
I know, but you're not explaining this enough for us to, really do a good job of it. So who is A, who is B, who is C, who is D? Why is there that, that line across C, D, and I
Okay.
don't understand this.
Yeah. Okay. So the
Or
C,
send us a document that, explains this and we can do the reading and then achieve this same thing.
okay. So here the P is the patient, that is the small kid who is like 7 years old. Here, the 7 one. So P is the patient here. I think it's now clear. And the patient's father and the mother.
Who?
Like K and J are the patient's father and the mother.
Okay.
Ashley, if I could
Yeah.
take up, Shalaka, actually, this family overview helps the interdisciplinary team to get know of the basic family history of the patient. Because since we are seeing not just the patient, his the entire personality. So just as I think Aparna has already answered most of your question in the chat, this helps in knowing the possible hereditary issues and psychosocial issues which might be involved with that particular beneficiary whom we are dealing with, that particular individual. So in this case, if we see this father and mother, they had maybe a miscarriage. No, from the K and J, if you could see, they have a miscarriage. So there
Sorry, I
might
can't
be
understand. They had a what?
miscarriage. If you could see there, the siblings of P, R, N, and O, and then there is a triangle with cross, which means a miscarriage.
Yeah.
If you So that helps the interdisciplinary team to know more about the genetic issues or genetic problems which might be involved with that particular patient. That is the importance of this family overview.
No, I understand that this is important,
Mhm.
when you're actually practicing palliative care, but from a case study point of view right now.
That is why I already said before she started presenting, if there is no hard fast rule that you should bring the entire family history to the table. If you are not getting the
Yeah,
family overview,
because
that is fine.
you're not explaining why a miscarriage is important from a genetic history point of view, right?
This is
So
the this is the family overview of just one particular patient. If you are not able to, if any of the participants are
no,
not
I want
able
to
to get,
understand this better and do a good job of it. So I want you all
I
to send us
understand.
some reading material, then we can do a better job of this.
I understand. Reading material will be provided later.
Shripriya, this is Aparna also. I wanted,
Mm-hmm.
continuing from where Shalaka has asked a question.
Mm-hmm.
Here you have the patient siblings at the bottom of the row, and
Correct.
then you have the parents,
Mm-hmm.
and you have grandparents, is it, on the top row?
Yes, correct.
So we have to do 3 generations, the
It
patient
is not
plus up
necessary. It
or
is not
down.
necessary. We provided this family overview only because we got the details. If you are not getting the details, that is also fine.
Okay,
You will come to know more when once we progress towards the end of the PPT. So
okay,
may I
okay.
request Ashley to move ahead and then maybe we can take up the questions at the end, Ashley. Hope that will be fine.
Okay.
Yes, you can just read through and then I would request everyone to note down their doubts and then we will take up everything. Thank you.
So here the Mr. K. Mr. K is the father of the patient. Okay. So Mr. K, child's father, has a stressful relationship with his siblings except Mr. E, the younger sister. Due to that, he has to build a house in the ancestral property by taking a loan. Even though the extended family would inquire about the status of the child, his father managed to get a visa to work in UAE, but he couldn't continue his job as his wife developed psychological disturbance as a result of his absence as well as dealing the illness of the child by her alone. As reported by the informant, she talks to herself, hears strange voices like auditory hallucination, poor sleeping pattern, sad mood, and also not performing well in household activities as well as in taking care of the other two kids. Early child in the family is about 12 years.
Ashley, if again I could just stop you here.
Yeah.
I'm sorry, but instead of reading this, we can also read it. Can you tell us the point of this slide? What are you expecting us to do here?
So this is like the family history of the child, explaining about his father, father, his mother's details, and also their relationship with others as well.
Okay.
So the elder child in his family is about 12 years of age, and he's also trying to help hard to help his mother in taking care of his younger brother. The middle child is of 10 years age, and she doesn't know how to take care of the struggle she is going through. The grandparents are also getting older, age-old pensions, and this is the sole income of the family. However, the father is trying to move from a permanent job as he has hope in the future as well. So this is the echo mapping. Here, we want to represent how the patient's family with others, like other socioeconomic factors like the religion, or how is the family well bound with the hospital setting or the schools. So here it is like evident in the right side, this positive straight line. The straight line shows that the family and the patient and his family has a strong relationship between the schools of siblings, the other siblings. And here in the religion, we can see a dotted line which clears that the patient and his family has a weaker relationship with the religion as well as, and also the extended family, as I mentioned earlier, there was not like okay with the family, like the father's family or the mother's family, they are not having a good relationship. So here in the echo map, it shows the patient and his family with other factors. So any doubt?
Ashley, we can move ahead.
Okay.
What is an eco map? What does the word mean?
So I think I will get back to you soon on that in the WhatsApp group as well. So this is the socio-economic overview of the patient, that is describing about the socio-economic conditions of the patients. So I think I don't want to read it out because already like this is circulated in the WhatsApp group describing about the socio-economic factors of that particular patients, that is what is there, how they are living, like what is the father's role. So I will get back to echo map as soon as I complete this PPT. I'll be back.
That I have already answered, Ashley. You can
Okay. Yeah. So here, the ration cards, what is the color of the ration card and what are the things they are getting as a subsidy there, and the financial support from anyone or anything, and detailing about the father's condition, what the job the father is taking, that is doing a coolie job for daily wages, and also the other family members, that is his the patient of the 7 years, his grandparents are also like ill members in that particular family. So telling about that also in here. And the treatment expenses, like earlier they have been consulted in a SAT, which is a hospital here in Trivandrum. So the expense of this treatment was like really high, so which they was not able to meet that, and also the educational expenses of the other siblings of that particular patient. And this is the psychological overview. So as I told earlier, this was a case which came to us through the helpline number. So we have not gone to that particular person in detail. This is just the information that we get from that informant, that is from his father and also his aunt. So in the psychosocial assessment of the patient was not possible because the case was registered through the helpline. So according to that family, It is saying that he opened his mouth and the lip movement was only when he was like really in hurry, hungry. And this is what.
Ashley, just to go back once more, the socio-economic overview. Who
Okay.
asks these questions about whether you have a house loan or not to the patient's family?
So
I mean,
in
who even gets that information?
whoever.
Can we have the questions in the end, please? Let her complete the.
Okay, so I will go back to the PPT. So this is what the Smriti ma'am was talking about in the first session about total pain, which we want to list about the physical, psychological, socio-economic, and spiritual factors here. So the physical aspect of the patient here, we can clearly see I am not reading out anything because like it's already visible there. So here, physical aspect is like the movement which should be written like completely bedridden or the cognitive impairment. So that all comes in the physical aspect, and the psychological factors, which includes behavioral issues or the mother having the psychological well-being, unwell-being, which is like, as I told earlier, that she was having some hallucination, auditory hallucination in the, I think in the second slide. And also the social economic impact, which is like acceptance, that is from separated, they are like separated from other family members, and also neglected parenting because his mother is not feeling well, the father is doing a job, so he is not able to take care of that child, etc. And also the financial crisis of that particular family also comes under the socio economic. And also spiritual, they have like, because of these issues in the family, they have like declined faith in life, and also they was also not getting any support from the religion. So this comes in this particular slide, and these are the discussion points in that particular presentation, which we will be discussing soon. So we, how they are going to survey, or what are the things that we can help, we can have to recover this mother's well-being, etc. And this was the plan which was made for that patient. uh, like we are doing, we would like to go for a home visit to explore more about this psychosocial issues or this, and also how can we provide education for the other children as well as, and also how to facilitate the disability pension for this particular patient, and also check with the PHC to avail diaper and medication for this particular family. So these all are the things that we want to include in this case presentation. And one more thing, I know it's not like a complete perfect PPT presentation. If once you have sent us the presentation, we will check it with the expert and we will rectify it soon. We will rectify it and we will get back to you on that. So questions here.
Okay, first I would take up the question by Shalaka. I guess you asked who would be asking the questions about gold loans and all. So, one thing we would like to make clear here is that the basic essence of palliative care is the interdisciplinarity. So, even if the doctor or the nurse fails to ask these questions, anyone involved in the care of the patient, starting from the medical social worker, the psychologist, the physiotherapist, even the volunteer who is involving in the case from the community, they can definitely probe the patient for these questions and collect the information. Our end aim is to collect as much as information as possible to help out the patient to live his life well, to ensure his quality of life. So the main point is who is not the question, but the main point is what are we asking and how are we getting the information. I hope that answers your question.
Shripriya, I have a question. The first slide where we have to give our name, title, and the organization we are associated with. Now, this is the first time I'm doing a course like this. So currently, I'm not associated with any organization. So,
No worries. You can just provide it as not applicable.
okay, thank you.
Then I see another question in the chat. Does the case study have to be based on a current patient situation or can Yes, of course, it can also be a past case. Our only intention is that now we have around 27 participants and in the session right now. So even if at least 4 or 5 participants gets a new information from one of the cases shared, that is what we require. Because some of you, maybe at least one of you, would have come across a similar situation in your practice. A 7-year-old child whose mother is having some psychological issues, whose father had to come back from abroad to take care of the child, and even the mother is still thinking that there is a chance for recovery of her child. So you might have come across such cases. So that is what we want you to bring in, so that people can know how to handle the situation, how the situation could be handled better and different.
Thanks, Shripriya.
Nita has asked plan and discussion slide what we need to do. Yes, of course, in plan, you can just, you might, in case you have got a case, you would have known what they had done. If, whether it is your organization or whether it is a friend or family circle, you would have known the plan at least. Whether they are going for the palliative care ahead or whether they are going for the alternative medicine ahead, that you would have got. For discussion slide, you have to put in your thoughts. Like, suppose in this particular case you are still in doubt what could have been done better for the patient. We already know it is a 7-year-old child who is not able to decide for himself, and the informant were that child's aunt and father. And then there we have this particular situation where the mother still doesn't know the prognosis. So how could we have managed the mother situation? The mother would have been facing burnout in this particular situation. So how we could have assisted her in addressing that burnout? Then there is the invisible siblings in the family. So they might also be having facing issues. When the mother and father are focusing their care on this particular child, the invisible siblings would also have been facing issues. So all these can come under discussion. So that is when you're preparing your PPT, you just put your thoughts into it and then check what could have been done better to improve the quality of the life, not only of the beneficiary, but of the entire family as such. I think we have more questions coming in. How soon do we have to submit the study before our scheduled presentation date? We would recommend everyone to bring in the case as soon as possible, because we need to get it vetted by the experts as well once. Otherwise, we would never want wrong information to be going to the participants. That is why we are requesting you to provide the PPTs in advance, so that our experts can vet and confirm that whatever details are going through the slides to you all is error free. And how one person is able to derive total pain working in a specific role. I believe that you are mentioning about the spiritual pain, the emotional pain and all. Is that, if I understand you correctly, Swati, it takes a lot of time. It takes a lot of time and experience to understand. Of course, the doctors can definitely find out the physical pain aspects easily, and a psychologist can maybe find out the aspects of the emotional pain. But then that is why we are repeatedly specifying the importance of the interdisciplinary team, so that all the entire team sits together, evaluates all the aspects of a particular patient and derive at the total pain concept. Of course, I can get back to you in detail if you can just message me privately regarding that. Can the case study be based on a personal or close? Can the case study be based on a personal or close family experience? Yes, definitely. Uh, yes, definitely, Darshana. That is why we said, if no, we understand that this particular group consists of people having medical exposure and non-medical exposure as well. So you can definitely bring in a case based on your personal or close family experience. Nothing to worry about that. Any other quick questions, Srisha, I can take up? I know we have run a lot ahead of the time schedule, and thank you everyone for being so much patient with us, because I personally didn't want this case reading session to extend beyond the second session. That is why I begged your time to stay with us. So, any other questions we can take in? I guess no, because everyone is silent. Uh, Swati, in communication topic, how these points can be. Yes, Swati, because I personally believe the communication is the best topic in which you can bring out more scenarios. Like, there might be situations where I can just say you in simple example where the patient knows everything, but he doesn't want the family to know that he's ill. Vice versa. The family knows that the patient is ill, but they don't want the patient to realize. Now, can you imagine the dilemma of the medical care provider who is in between this? So that does have a scope for bringing in all these points, handling the communication aspects, like how to communicate to the patient. Some people, we always end up like, I am a non-medical person, but I end up hearing medical jargons from my doctors many times, which I don't understand a single word. And there are doctors who communicate to us very clearly in common man's words, right? So these aspects definitely can be included in the case presentation which you are planning to bring in communication, where you have you might have felt that things would have been better if the matter would have been communicated in another way. So all these I am saying very generally. I know I am just it's like beating around the bush, I guess. So once you bring in your particular cases, we can definitely have our experts go through them, bring in their valuable comments, and then we can share the done.
So Shripriya, I just have one last question.
Sure, Dashno.
So I understand that the intention of this presentation is to report a patient or a family's experience based on what actually happened, right? Because there are so many classes to be covered, talking about
Exactly.
communication, grief, spirituality, and a lot more. And if we were to
Correct.
weave in, the takeaways from those, then we wouldn't be able to do this now.
I understand.
So is the goal simply to present the actuality of what happened, or
Correct.
kind of offer a perspective of what could have been done differently?
Yes, exactly. Our intention is to bring in the cases in a layman's perspective, basically, where there was a dilemma or where was there a confusion, and then we have to sit together and discuss what could have been done better from a palliative care perspective to improve the quality of the beneficiary. That is our aim.
Okay.
So once you bring in a case, all of us will sit together in this session. We will discuss the case, and the experts will put in their points, their comments, how this could have been. Now there have been instances where they were in doctors' batches, they had brought in live cases, and then we supported them later. Like we provided them improved medications, we provided them tele-counseling. Even in non-medical cases, we have a telehealth live helpline running, and if the case you are bringing in needs support, we will be definitely able to do that. So
Okay, got it.
apart
Thank you.
from you being equipped with the knowledge about palliative care, our aim is that at least if one patient out there gets benefited out of these cases, that would be more beneficial, right? That is what we are thinking. I hope that answers your query, Rasha.
Yes, Shripriya.
If there are no more questions, I think we can wind up for the day. Ashley, it is over to you.
Yeah, okay. So thank you all for joining this session. So if you are having any more queries, please feel to reach out me or Sri Priya either in the group, or you can just message in the WhatsApp group as well as. So thank you all. Thank you for joining the session, and see you all in the next session. Thank you.